Good afternoon, everyone. Thank you for joining us for the fourth webinar in our Refugee Health in Primary Care webinar series. Today, the webinar is about common conditions and case studies in refugee health. Before we start, I'd like to acknowledge and pay respect to the Whadjuk Noongar people upon whose land we are meeting. I honour their elders past and present and recognise the continuing connection of Aboriginal peoples to their lands, waters and culture. I also recognise the diversity and strength of Aboriginal peoples and the significant importance of self-determination and cultural knowledge in supporting the positive health and well-being of the whole community. Just a note that your cameras and microphones are enabled. So if you do want to pop your cameras on, then please do. If you do want to ask a question, I encourage you to please pop it in the chat and we will answer it at the end of the webinar. Just to note that no AI note takers are permitted in this meeting, please. And I'd love to introduce our speaker, Dr. Zoe Smythe, who is a Senior Medical Advisor at the Humanitarian Entrant Health Service at North Metro Health Service. And I'll hand over to her now. Thank you, Dr. Zoe.
Thanks, Michelle. So I'm very pleased to be with you here again to do another webinar. This is the fourth in our series of 6. And today we're going to be talking about some common conditions that we see in refugee health, looking at a few case studies and also looking particularly at referral pathways in refugee health. So Michelle has already done an acknowledgement of country, but I'd also like to acknowledge the Noongar people as traditional owners and custodians of the lands on which we work and pay respect to their elders, both past and present. North Metropolitan Health Service recognises, respects and values Aboriginal cultures as we walk a new path together. So the talk today is really split into 2 parts. To start with, I will go through some of the common and less common but important medical conditions we see in refugee health that perhaps are not always commonly seen in general practice. And during the second half of the talk, I will also try to give you some practice points to cover your approach to issues such as chronic disease, mental health and women's health. Obviously, an hour is not long enough to go into each of these areas in any great depth, but hopefully I can give you some tips and most importantly, some info on those referral pathways and where to go for more in-depth learning and advice. So firstly, I've just put a slide up there that I did show in our first talk as well, but looking at some of the screening outcomes in our service for the 2025. So some of the conditions that we more commonly see. So you can see there vitamin D deficiency, iron deficiency, B12 deficiency, also some parasitic infections such as schistosomiasis and strongyloides, and then things like anemia, hypocalcemia and chronic hepatitis B. That's not all that we screen for, but it just gives you a flavour of the sort of things that we commonly see. So I'm going to start off talking about some of the infections that we see and treat. So looking at the common and also those not to be missed. So I've got a few case studies that are used through this talk. I have changed some details. They are based loosely on cases that we've seen, but I've changed some details. But the first case study is a 32-year-old lady born in Myanmar who travelled from Thailand, had lived in a Thai refugee camp. And she reported at the first visit with us that she'd seen a GP on arrival in Australia for cough and he treated with antibiotics, but she'd not really improved. During her second visit, a little bit more history was obtained, and she actually gave a history of some rapid weight loss in the past, several years ago, and said she was treated for anemia at that time. But she also reported some new weight loss in the last 3 months. So she actually, we worked out that she'd actually lost 10 kilograms by looking at what her current weight was and what the weight was in her overseas health information. So thinking about possible causes, you've probably already got some in your mind, but we gathered a bit more information and we actually discovered that a friend of hers had been treated for TB 1 year previously. She had had a normal chest x-ray 2 months prior to travel. On examination, she had a small cervical lymph node that had been present for 6 months. She said it had been reducing in size. We did some induced sputums the next day and she was reviewed by the WATB control program doctors within a week. So her FNA of the lymph node that we also organised was negative, but her sputum was positive for TB and that was confirmed on culture. So this is not a common finding in our clinic. So we don't commonly see active TB, but it's certainly one important thing that we don't want to miss. people do have, as I've talked about previously, extensive screening overseas. They do have chest x-rays, children have quantiferon blood tests done, but this case just highlights that you still have to maintain that awareness that TB, can still present soon after arrival or much later sometimes. So looking at TB and latent tuberculosis infection, about 90% of TB in WA is in migrants from high prevalence countries, or high incidence countries, I should say, really. Screening for those arriving via humanitarian pathways, as I said, is pretty comprehensive, but you do have that risk of reactivation around the time of migration. Think of TB with other unexplained symptoms in other sites as well. So lymph node enlargements, but also bony symptoms that are a little bit unusual, or skin lesions that are unusual, genitourinary symptoms, abdominal symptoms, because extrapulmonary TB also accounts for approximately 40% of cases in WA. In our service, we have positive quantiferon rates of around 10%. So everybody that comes through our clinic, unless they've had a definite active TB that's been treated in the past, we will do a quantiferon test on everybody, and about 10% are positive. Medicare doesn't support universal screening with quantiferons, as you would know. So patients, if you request them, unless they are a contact of somebody, may get a bill. So that's something that we are advocating for through the Refugee Health Network of Australia, in just trying to see if people, at least for a period of time after arrival in Australia, may be able to access quantiferon blood tests, but just so that you know, everybody coming through our service will get one. And if we have people that are going to rural areas that we won't see, then we're also happy to work with GPs to maybe do the request form, and so that can be billed through our service as well. Latent tuberculosis infection treatment can reduce risk of reactivation by up to 90%. So the numbers needed to treat there are often quoted as 11 to 30. So we do refer everybody with a positive quantiferon with their consent to the WA tuberculosis control programme. So that's they are co-located with us at the Anita Clayton Centre, which is really convenient for us and for our clients. They run adult and paediatric clinics and really provide comprehensive case management for cases. And they have developed very comprehensive guidelines for tuberculosis control in Western Australia, which are available. And I'd also like to highlight that they're really approachable and available for GP advice if you do have concerns about patients. A really useful resource. So moving on to a second case study. So this was a family of 9 people, 7 adults and 2 children, who'd been living in refugee camp for around 17 years. On initial screening, 5 of the family members had a positive serology test. So I won't say what it was for, but one family member had an equivocal serology test for this condition. So I've included some photos. They're not photos from our clients, they're just photos from Google Images. But I wonder if you can think of what I'm talking about here. So I think some of you would recognise that this is strongyloides infection, and the photos demonstrate cutaneous lavicarens, which is the classical migratory rash of strongyloides that actually occurs when autoinfection is happening, although we rarely see this. I've not seen this rash for many years actually, but when it does occur, it can sometimes start in the perianal region and rapidly spread, causing intense itching for several hours before subsiding. So it is very transient, but if somebody does give a history indicating that they've had this sort of rash, then it's worth thinking about strongyloides. Generally, we pick up cases through screening with positive serology. The serology should eventually revert to negative after treatment. So it can take some time, so it can take really up to about 12 months. But after successful treatment, the serology should return to negative. So the management of strongyloides is generally with ivermectin, which we prescribe according to weight, and that's through the PBS, through an authority. usually 2 doses 14 days apart, given with fatty food. With adults and children over 15 kilograms, there's 200 micrograms per kilogram. More recently, the therapeutics guidelines has detailed that children above 1 year of age, but less than 15 kilograms, can also receive ivermectin, rather than the alternative, which used to be albendazole, at a dose of 3 milligrams for ivermectin. If people have immunocompromise, but uncomplicated infections, so again picked up on screening, then sometimes we give 4 doses of ivermectin instead on days 1 to 15 and 16. So going back to this case, we do send stool samples when we pick up strongyloides, really to see if there is parasite present, to get an idea of the burden of the infection. And generally samples are negative, actually, usually. In this case, we sent the stool samples, but were contacted by the lab to say there was one of the pots was empty. So we actually, with our clinic, the first visit, we give people stool pots, and the second visit, they bring it back. And if we need to send it because of the serology blood tests, or because people have symptoms, it just makes it really convenient. And obviously, if we don't need to send it, then we discard it. So one of the people had handed in a pot that didn't actually have anything in it. And that was a child that was subsequently seen at PCH several weeks later. And at the PCH appointment, they managed to obtain a stool, and we got a call a couple of days later from them saying that they'd found a lot of parasites, teething parasites. So because this occurred several weeks after they had all been treated, we obviously were a bit concerned that the treatment hadn't been successful. So we routinely, at that point, retested people after 6 months with serology to see if it had reverted to negative. For this family, they were all still positive for strongyloides at 6 months, and concerningly, most actually had increased titers of strongyloides on the blood test. So after discussing with infectious diseases, we decided to retreat at that point. So usually we would wait another 6 months before doing that. We decided, because there was this concern about the child not having been successfully treated, we would treat everybody again. And then we arranged further follow-up blood tests, and most were still positive after 1 year. And then it became very complicated following this family up, because they were all busy, several were working, and trying to get hold of everybody and refer everybody to infectious diseases to follow up further was a little bit challenging. So it raised the question in this family, was the sort of ongoing person-to-person transmission, which for strongyloides is not supposed to really happen, but can happen occasionally, and was the ongoing infection in one family member who was spreading it to other family members. So we decided, after the difficulties following up this case, that we'd look back and see what our results were like, so whether we were actually managing to cure people of their strongyloides in terms of their serologies becoming negative again. And we found actually that at 6 months, there's relatively few people we could say were cured. So because it was so resource intensive bringing people back for blood tests, when it's difficult sometimes to contact people and get them back into our clinic, we decided to extend the follow-up to 12 months, because it seemed that it was taking longer for the blood test to revert to normal, except for those that were at high risk of strongyloides infection, so those that were really immunosuppressed. We decided to continue to screen and treat people, even if they'd received ivermectin on departure. So this was something that was brought in a couple of years ago, where people coming from high prevalence countries started to be treated with ivermectin on departure. But we decided that we would continue to screen and treat, because it did seem that it was quite challenging and difficult to successfully treat people. So with these parasitic infections that we pick up, mostly they are picked up, as I said, through positive serology, or because people have symptoms, and so we send a stool for OMP because they've got the symptoms, or because they have eosinophilia on their blood count. Strongyloides itself is a soil transmitted helminth. So typically, classically, people get strongyloides walking around barefoot in areas where the soil is contaminated. it can cause dermatological, respiratory, GI issues, and can contribute to chronic malnutrition in children. As I already mentioned, this autoinfection term, this allows the infection to persist for many years. So basically, the parasite can enter the gut, get into the bloodstream, get into the lungs, and then people cough it up and swallow it back down. So the whole life cycle can occur within the human body, and it can be repeated multiple times. So it's possible that people can have strongyloides infection for decades. Generally, although I said it can cause all of these symptoms, generally most people with it are asymptomatic. But it's really important because if people do have strongyloides, they can develop a disseminated infection, which can be fatal in immunocompromised individuals. So that's really why we want to pick it up and treat it. I think especially now where people become immunocompromised for all sorts of reasons, and many of our medications can cause immunocompromise. So I think in people coming as refugees from high-risk countries, it is important to pick it up and treat it so they're not at risk in the future. It is a WHO neglected tropical disease, so there are ivermectin treatment programs around the world. As I said, all refugees from high prevalence areas are also treated on departure. We have to be a bit cautious in using ivermectin in people from areas endemic for lower. So we're getting into kind of small print stuff here, but I think for us it's important because we do see people from countries such as Congo and South Sudan where lower is endemic. So giving ivermectin to individuals with lower can cause serious adverse effects, including things like dizziness, confusion, seizures, especially if they have high microarterial densities. And if you are concerned about the possibility, so somebody's come from one of these endemic areas, you can screen for lower using daytime Giemsa-stained thick and thin blood films. So those blood films have to be taken in the middle of the day between 10 a.m. and 2 p.m. So small print stuff, but can still be, important if you are seeing patients from various areas. So the next pictures I've got represent another infection, and you can see I've got a map there showing the endemicity, picture of the parasite itself, and then a picture of some of the effects that it can cause. So many of you probably recognise that I'm referring here to schistosomiasis. So, sorry, go back to the picture here. So that's an ultrasound of the bladder showing bladder wall thickening. And that's obviously the schistosomiasis parasite. So it's caused by these trematode worms after exposure to fresh water contaminated with feces or urine. So these freshwater snails act as an intermediate host. It's still a problem in many countries, and there's still actually 12,000 deaths annually worldwide from schistosomiasis. But the number of disability-adjusted life years lost is much higher, so 3.3 million. So it does cause chronic disease. Acute infection, so Katayama fever, can occur 2 to 8 weeks from the time of infection, which may include a rash, fever, cough, diarrhea. I think you're much more likely to see that in return travellers that have inadvertently exposed themselves to schistosomiasis than we are in our refugee clients. But it's just important to bear that in mind. Generally, we see it in refugees from sub-Saharan Africa, Myanmar, Iraq and Syria, and parts of South America. It's not commonly seen in people from Afghanistan or other areas of the Middle East. In fact, we don't tend to screen for it in people from those countries. It can cause this chronic infection, which is mediated by an inflammatory reaction to the eggs, which is ongoing over many years sometimes. So urogenital schistosomiasis, hepatosplenic are probably the ones that you're most aware of, but it can also cause intestinal granulomatous reactions, neuroschistosomiasis, pulmonary schistosomiasis, so really a whole range of effects. I don't know how clearly this is coming up on your screen. It's very small on mine, but it just is a flowchart that shows what we would tend to do. So if people have a positive serology for schistosomiasis, we would then collect a stool and a terminal urine to look for parasite, again to see what the burden of infection is. And we'd also treat with praziquantel in usually two doses taken 4 hours apart. If there's no overseen on the stool and urine, then generally we don't follow up those patients unless they've got eosinophilia on their blood count, in which case we would repeat the blood count in 3 months later. If over are seen, then we look to see whether they've got signs of a complicated infection or whether it looks more like they have an uncomplicated infection, and potentially if they looks like they've got a complicated infection, we'll arrange for renal ultrasound, liver ultrasound, refer to ID, depending on what sort of things are showing up there. So with schistosomiasis, unlike strongyloides, the serology remains positive for life. So it's actually quite useful to know when somebody arrives in Australia, if they have been exposed in the past. Obviously, we treat them if we find that they have been. But if in the future they return to visit friends and relatives, they return to an endemic country, it can be useful to know what their serology was when they arrived in Australia, because if they are exposed again, obviously it can change. They may have a new infection. It's worth mentioning that as also that praziquantel has been difficult to obtain over the last couple of years. So the TGA approved brand was withdrawn from the market a couple of years ago. We ended up sourcing some stock from overseas and were able to prescribe that through approval through the TGA Special Access scheme. So we had to do an individual approval for every patient that we saw. Now it is actually, there is a Section 19 approved medication, which the pharmacist tells me means that it already has a temporary sort of TGA approval. So I don't know how easy that is for GPs to access at the moment, to be honest. I don't know if pharmacies, community pharmacies do have access to that, but we have managed to supply to secure a stock for our clients, which is good because we do actually see schistosomiasis pretty commonly. So again, around 10%, similar to strongyloides. Okay, so moving on to another case study. So this was a young adult female from Myanmar, again via a Thai refugee camp, who was well at her first visit, but she did report having had multiple episodes of malaria treated previously, with the most recent being about a year prior, when she was, sorry, a little typo there, treated with quinine, which is, I guess, a slightly unusual treatment to use first line, but that's the history that she gave. So we screen people from malaria endemic countries, and our lab often does this LAMP test. So it's a newer test. They do that instead of a malaria antigen test, especially when they have a group of people that we're testing together. And it's a very sensitive and specific test. So for her, this LAMP test was positive, but there were no parasites seen on the blood films that were sent. Later on, a few days later, a PCR, which we always use to confirm the species, did show falciparum malaria. She had borderline low platelets, but otherwise no abnormalities in the rest of her bloods. Now, as always is the case, these results always come in at the most difficult time, and this result was received, I think, after hours on the Friday at the start of a long weekend. So there was some difficulty locating her initially, and when she was located, then we managed to arrange an attendance at an ED because our clinic was closed, and we were closed for the next few days. So she went to the ED, but we did arrange to see her early the next week. And when we saw her at our clinic 4 days later, she was still well, so she still hadn't been unwell. She reported that she'd been given a script for Riomet in the ED. There'd been a couple of days where she wasn't really sure what to do with the script. Eventually, a relative helped her to take it to a community pharmacy. The community pharmacies don't tend to stock Reamet and had to order it in. So it was another day or so delay while they ordered it in. And then the day before we saw her, she had started taking it, but she'd taken a very low dose, I think like 1 tablet twice a day, where usually it would be 4 tablets twice a day. So we restarted treatment. We were lucky enough to have a face-to-face interpreter who is a really amazing interpreter and really helpful, and was able to actually write down timings for her, so to help her with the doses, because anybody who's prescribed Reamet will remember that although it's sort of 4 tablets twice a day, the first 2 doses are supposed to be taken 6 hours apart, and then there's 18 hours till the next dose. So it actually seems much more complicated than it probably really is. We observed her take the first dose in clinic, and we safety netted a lot. So took a long time explaining to her what to do if she felt more unwell. And we gave her a letter to carry, stating that she was being treated for malaria. And we followed her up again with a phone call a couple of days later to make sure she completed the course of Reamet and repeated bloods on days 7 and 28 to confirm. And as I said, we confirmed that she completed the course of medication. So this case just led us to kind of reflect on some of the risks for our clients. So the first one, the big one, is, I think, communication issues. So obviously, people not being able to speak English means it can be really challenging, to have to find interpreters. And for the ED departments as well, often they're maybe trying to use telephone interpreters, which I think can be harder in some ways. Also, contacting people for us in itself is difficult, because usually families are given 1 mobile phone between them when they first arrive. Over the next few weeks, generally most adults will get their own phone, but for a while they're just relying on 1 phone. And for these large families, that can prove difficult to locate the right person. Lots of difficulties navigating the health services. So I think that's a really common amongst our clients, that they do find it very difficult in the hospital system and in primary care in the early weeks of arrival. We also realised that community pharmacies don't have access to Reamet. I don't know if that's universal, but I certainly phoned a few just to try and find out if any near us did, and it seemed that they usually have to order it in from wholesalers. And where she came from, so being from a Thai refugee camp on the Myanmar border, is a really high risk area for Reamet resistance as well. So there's a possibility that her malaria, may well not have, might not have been treated with the standard course of Reamet. So we just had to make sure that it did resolve. So we developed guidelines really after this case, specifically around malaria, to support testing and treatment of malaria in the community for our patients. And we decided to stock Reamet and Primaquine in our on-site pharmacy to facilitate that. So Primaquine is the medication that you can use with Vivax malaria or malaria ovale if you need to use that terminal treatment, as long as people's G6PD level is normal. But we always liaise with tertiary hospital ID when treating malaria. So we'll always make a phone call to let them know that we have somebody, and just to make sure that they're happy with the plan to treat them as an outpatient. So in 2021, malaria was the 2nd most common cause of morbidity in refugees worldwide, according to the UN data. And going back another couple of years, in 2019, it was reported to be the most common cause of mortality. People are screened on departure from endemic areas and are treated before they travel if they screen positive. So those people do require follow-up on arrival to Australia, is something that we usually will manage. Adults can often be asymptomatic or minimally symptomatic because they have these low density parasitemias due to partial immunity that they've developed from repeated previous infections. So it's quite common for people to tell us that they've had malaria multiple times in the past. And for adults, that does induce this partial immunity, which means they don't usually get terribly sick from it when they have it repeatedly. P. vivax and P. ovale species, as already mentioned, require that terminal treatment with Primaquine as long as their G6PD level is normal, to eliminate the hypnozoids that hang out in the liver. Children and pregnant women are really high risk of severe malaria and may deteriorate rapidly and require urgent specialist review. So certainly we wouldn't be treating children and pregnant women usually as outpatients unless it's under the supervision of the relevant ID clinics in the tertiary hospitals. This partial immunity that I've talked about really decreases over 1 to 2 years after arrival in non-endemic countries like Australia. So that can be important when considering in the future that people often do visit friends and relatives and return to those high-risk areas. Because families, I think, do often underestimate their risk, especially for children that have either been born here or have migrated here at an early age. And certainly I had a lot of experience working previously in London, where we saw a lot of malaria in children in the ED department where I worked, and it was usually from people visiting family overseas. So I think GPs and practice nurses have a really important role there to counsel people about that as well. So before we move on to other things, I've got a few other parasitic conditions that I just wanted to quickly mention. And I've got some photos here. There's 5 different conditions. So moving across the screen, you can see the last one on the right there, there's an ECG and a bug. But I'm just going to have a sip of water and give you a couple of, just a minute really, to have a look at those and see if you know what I'm trying to refer to here, and then I'll take you through each of those briefly. Okay, so before anybody thinks that the webinar has frozen, I will move on. So the first one is that common parasite Giardia, and I'm sure you've all seen this. Obviously, we have it in Australia as well. But it is being picked up quite commonly in our clients because I think the newer PCR testing is very sensitive. So often when we do send off stool samples, we do pick up Giardia, and it can cause GI symptoms and growth faltering, obviously, in children. And so when we pick it up, actually, I usually find that people have had some sort of symptoms, and so we do usually treat it with metronidazole. This picture shows an amoebic liver abscess. So a liver abscess caused by Entamoeba histolytica. And this again is another infection which we're not commonly picking up, but we have had a few cases that we've detected via sending us stool samples, because again the PCR tests now are much more sensitive, and it's still very prevalent around the world. So it's estimated to infect 35 to 50 million people and still kills more than 55,000 people a year. I was quite surprised by that figure. It was higher than what I had thought. It can be treated with metronidazole, but that is not active against the amoeba cysts that are in the bowel. So the common scenario when we pick it up is that actually people don't have liver abscesses. We just pick up the fact that they are carrying entamoeba. So the most useful drug in that situation is actually paramycin, which is good for eradication, asymptomatic carriage, and will prevent people passing it on to family members and prevent them from getting a complicated infection in the future. And that drug is available via the TGA SAS. So I just thought I'd mention that in case you also have some stool samples coming back with these unusual bugs. This is pictures representing lower, which I mentioned earlier in the talk, because the issues around giving people ivermectin, commonly called the eye worm because of the, famously moving across the eye, I should say. I've seen one person with this, but actually not in the context of doing this job. But you don't forget it once you've seen it once, I don't think. It is a filarial infection transmitted by the bite of a female tabanid fly, I don't know if I've said that correctly, found in Central and West Africa. People also can get these episodic swellings in the limbs associated with urticaria and itch. So again, not a common thing that we would see in general practice, but one that, you just have to bury somewhere, so that if you ever see anybody that has travelled or lived in these areas, that you might just realise what might be going on. Cutaneous leishmaniasis. This is an infection that we've seen. Again, these photos aren't from our clients, but this is an infection that we have seen. And it's the most common form of leishmaniasis affecting humans. There's many species spread through many parts of the world, through tropical and subtropical regions, including the Middle East and Afghanistan. And the case that we saw did come from that area of the world. It can cause non-healing raised scaling lesions that may ulcerate and become secondarily infected. So the picture there is quite a sort of classical picture, but before the lesions become ulcerated, they can sort of appear more raised and scaly, which I guess could be mistaken for things like discoid eczema or psoriasis. Finally, Chagas disease is one that I think is really interesting. Found in South America, and actually now is almost thought to be endemic in the southern US because of the amount of migration that occurs from South America to the southern US. It's spread, traditionally the main route of spread was through the bite of this kissing bug, but importantly, it can also be vertically transmitted and transmitted through blood and organ donation. So I think the vertical transmission is really important to consider because, you know, women are at risk of passing it on to babies, and it is often asymptomatic in the early stages. People from endemic countries can donate plasma in Australia, but they can't donate other blood products because of the risk of transmission through blood. So it's really considered an emerging infection in countries with South American migrant populations. I attended a really interesting talk by a visiting professor from Spain, who obviously Spain, because of the common language, do have a lot of South American migrants, and she did sort of talk about it as being, you know, this emerging infection. So we have had increased numbers of South American migrants in the last few years. So we have decided to commence screening for Chagas disease, and the Royal Children's Hospital in Melbourne have done a piece of work really around this and developed some guidelines. People with Chagas disease, chronic Chagas disease, are at high risk of heart disease and cardiomyopathy. So 20 to 30% may develop that in the future. GI complications, megaesophagus and megacolon. It damages the nerve endings, and this is what leads to this sort of manifestations, and neurological involvement as well. And there is a risk of reactivation of the infection with immunosuppression. So it's another one there where immunosuppression can be important. And one last parasite before we move on. So I thought I'd covered everything, but then I had a thought. Actually, neurocysticercosis is an infection of the brain by the larval stage of the pork tapeworm. And it's really interesting. It's the most common preventable cause of epilepsy worldwide. So 2 to 4% of cases of epilepsy worldwide, about 1 to 2 million people. Especially obviously in endemic areas where pork is consumed. So some groups of refugees we have, you know, don't eat pork, and so they're at lower risk. But in areas where pork is consumed, it may cause up to 30% of epilepsy cases. We have to be a bit cautious when using albendazole. So albendazole we sometimes give people as a sort of to treat other parasites in the gut if they haven't received it overseas. But if somebody has a history of seizures, then I would be a little bit cautious about using albendazole because it can increase symptoms by killing the viable cysts in the brain and triggering inflammation. So in practice, ID physicians, if they treat this, often give steroids concurrently. So I think I put it on here really just to remind people that our clients have not had the same access to medical care and workup of, you know, different medical conditions as we would expect to have in Australia. So may well have had epilepsy diagnosed without ever having a brain scan. So especially if they're coming from these endemic areas, it's probably important just to organise that to make sure there's nothing unexpected like this. And this is, I was actually contacted a few months ago by one of the ID physicians at one of the tertiary hospitals to let me know that this is something that they had seen recently in a certain group of migrants from one of the Asian countries. So it is occurring in Perth. So moving on now to talk about some of the nutritional deficiencies that we see. Firstly, anemia and iron deficiency. So globally, WHO estimates that about 1/3 of non-pregnant women, slightly more pregnant women and children suffer from iron deficiency anemia. We don't see that degree of iron deficiency anemia, but we do see about 20% of patients that have iron deficiency. And I think if patients have microcytosis and normal iron levels, or they're pregnant with microcytosis, then obviously considering HB studies as well to look for things like alpha thalassemia, beta thalassemia traits, noting that Medicare do have guidelines around this now, so you can order HB studies, is my understanding, but they won't do the alpha thalassemia DNA testing unless people are of sort of childbearing age. Also wanted to mention about IV iron. So we've had a few instances where people have seen GPs in the community and been prescribed IV iron, but the cost can be really prohibitive. And we do find people tend to respond pretty well to oral iron, even with, you know, fairly significant anemia. Obviously, side effects can be an issue, but our experience is that it's often worth trying oral iron first and seeing if people can tolerate that. And I've just put a few other causes, the common causes of anemia over there, and then that box on the right. So I know this is bread and butter for GPs, but just thought I'd give a little insight into how I approach it in refugees. So assessing dietary adequacy, food security is, I guess, important because you want to try and explain why somebody has iron deficiency or even an iron deficient anemia. And food security obviously can be an ongoing issue even after people have arrived in Australia as well. I always specifically ask about menorrhagia because I find that that's often not volunteered. And considering fibroids, especially in our refugees from sub-Saharan Africa, they're thought to be 3 times more common in Black women, and they tend to occur at a younger age, larger, more symptomatic. And certainly I felt quite large fibroids as abdominal masses in a couple of our clients. So just being alert for that. I always think that the red flags include when maybe there's only one family member affected, because usually if food insecurity is affecting a family, you often see that these nutritional deficiencies will be throughout the family, or at least, for example, with iron deficiency, maybe throughout the children at least. Men or postmenopausal women obviously have a higher level of concern if you see it in men and postmenopausal women, because the risk should be lower. So if they do have iron deficiency anemia, probably need to think about excluding other things. And with GI cancers, just noting that H. pylori, which is a common infection in refugees, there are those links with gastric cancer, and the rates are high, especially in people from some countries such as, for example, Iran seems to have very high rates of H. pylori infection, gastric cancer. And people may have a family history. When you ask about the family, sometimes the information can be incomplete. People really aren't sure what cancer relatives had, but people, you know, haven't had the access really to the sort of preventative health that we do, you know, asking in detail about family history, and also don't have access to, you know, healthcare in general or screening, so may have, you know, had symptoms for some time without it being picked up. So we do end up ordering quite a few upper and lower GI investigations with iron deficiency anemia, especially in adults without, you know, we don't, although we realise that it may be because of nutritional deficiency, we just need to ensure that there's nothing else going on. And poor weight gain in children and underweight adults, also a flag for celiac testing, because celiac disease, the prevalence through the world, as many of you would know, is it's quite interesting, quite high in some areas of the world where we're having people that are migrating from. B12 deficiency, the rates that we pick up are fairly high, so 15 to 20% in newly arrived refugees. So usually people will have a normocytic picture on their blood count. Often they're not anemic. Often, you know, they just have the B12 deficiency without anemia. They can have concurrent iron deficiency, which is maybe why we don't see that much macrocytosis. It's often attributed to the lack of animal source foods in people's diet. So again, that food insecurity, and potentially also GI parasites and high H. pylori infection rates are also supposed to contribute to B12 deficiency. In practice, we see it, I think, most commonly in refugees from the Middle East and Afghanistan. We usually treat with IM B12. So in our clinic, we provide that for free. We're giving so many immunisations, people often don't notice that they have an extra injection, or they don't notice. We obviously counsel them for it, but they often don't mind having a needle. But oral B12 is also an alternative. We're often sending people away with vitamin D and iron, so I think sometimes they just prefer to have that injection. But I recognise that it's not available on the PBS for this indication. There's some uncertainty regarding the longer term progress after arrival in Australia. So it used to be sort of said that within 6 months, people are eating, a different diet maybe, and B12 deficiency will resolve. But I've seen research that doesn't necessarily back that up. So they probably do need follow-up with B12 levels done. There's obviously, as I already mentioned, ongoing food insecurity issues, and people are often struggling to buy more expensive foods like meat. So it can be an ongoing issue. Red flags for me, if there's a single individual in a family affected, then I would see that as a bit of a red flag. Like, why is one person impacted and the others aren't if they're eating a similar diet? Or if people have significantly low levels from some of the countries that appear to have a lower prevalence of affected individuals. So did recently pick up a case of pernicious anemia with positive antibodies in a gentleman from Myanmar. We don't usually see B12 deficiency in refugees coming from Myanmar, so it was a bit unusual. And when I did the further investigations for him, then it did show that he had another reason for his B12 deficiency. Vitamin D deficiency, this is the commonest thing that we see, rates of over 50%. I know this is very commonly seen in primary care. We're all used to treating it. Higher risk of ongoing deficiency, often due to their skin type and levels of exposure due to lifestyle, etc. I think it's difficult for us to really comprehend how many symptoms it does cause, because we don't have the ability to follow people up really long term. But lots of people that we see are complaining of non-specific bone and muscle pain, fatigue with exercise, and I suspect in some cases it is due to vitamin D deficiency. In children, it can contribute to poor growth, irritability, and delayed motor milestones. The Children's Hospital, any of you that have had children seen at their refugee clinic, you'll know that they do tend to give STOS dosing. Whereas at HES, we tend to try daily dosing, first of all. So a dose of either 1,000 or 3,000 units, depending on how low their vitamin D is. You can obviously also give it weekly. By the time the children get to PCH, they usually had a trial of daily vitamin D. So if that hasn't worked, or they still consider them to be at ongoing risk, they often will give a STOS dose, but we don't have that available. And I also counsel people about the need for ongoing prophylactic doses, especially in winter, if there are ongoing risk, and discuss dietary intake of calcium and consider the need for calcium supplementation. We also do assess children for possible rickets if they're vitamin D deficient, and we check calcium levels in children under 19 years of age. I'm not going to go into a lot of detail with rickets, because I think the next talk is from one of the paediatricians, and I suspect that he'll probably mention that. But things to look out for, common things that you may see are sort of delayed walking, sometimes the typical bowed legs, delayed dentition is a big one, and delayed fontanelle closure, various other things that I'm sure you're aware of. So with hypocalcemia, we do see this fairly commonly in children. As I said, we do check calcium phosphate levels in all children under 19 years of age. And in terms of trying to prevent hypocalcemia, we do routinely supplement with calcium, unless there's a reason not to, as well as vitamin D when we have people with levels of vitamin D of less than 15, or we discover they have a poor calcium intake. We also use a lot of caution with vitamin D supplementation until calcium levels are normalised. If we do pick up a low calcium, we'll generally try and correct that with calcium supplementation before starting vitamin D, just because of that risk of lowering the calcium further and causing symptoms. So 2.6% rate of hypocalcemia in our paediatric population. And adolescent girls definitely seem to be highest risk of deficiency. And usually those girls have a very low vitamin D level as well. And we usually check magnesium and a PTH. And PTH, obviously usually will be mildly raised because of the vitamin D deficiency. Often the children are asymptomatic, but you can see severe hypocalcemia, and we have had at least one case I'm aware of in the last couple of years where the young girl was admitted to hospital for IV calcium because she had really a very low level and ECG changes. So occasionally you'll get severe cases, and she also did have some physical symptoms such as tetany as well, paresthesia. We define kids at sort of high risk, the ones that we would generally talk to PCH about, and we came up with this kind of little guideline after discussing with them, would be those that have a calcium level of less than 2, or those that are under 5, because the calcium supplementation that we have is going to be difficult. We have, chewable calcium that's going to be hard for younger children, or those that have any symptoms. Oh, sorry, I realise that we're going to move on a little bit quicker because we are running a little bit short of time. So with mental health, I just wanted really to highlight a couple of things. So the STAR MH is a tool for culturally appropriate screening. Culturally appropriate screening tool. I've got a link there, but you can Google that and sign up for that. And I think it's important to try and recognise what is expected stress from resettlement versus pathological mental health issues. It can be challenging to recognise that, and we do try and build on strength and resilience and educate about options for accessing support and addressing stigma. So those with mental health pre-existing major mental health diagnoses, there's a few things that we find. So we find that diagnoses may be inaccurate to start with. Clients are sometimes over-medicated with sedatives, etc. They can be experiencing side effects. The medications they're on may be unavailable in Australia or unsupported through the PBS. Sometimes people have coexisting dependency because they've been prescribed benzodiazepines and opioids. And we often find that the process of settlement increases stress, leading to decompensation. We sometimes also find that access to appropriate services can be hard. For example, assets, who I'll mention in a minute, may not be able to accept clients with major mental health diagnoses, and obviously cost can be an issue for our clients as well in terms of trying to access private services. And the need for evidence to access appropriate support such as NDIS and DSP can be difficult. So assets, a really important organisation to highlight. They see people from refugee-like backgrounds who've experienced trauma and can provide counselling. They also have community development and capacity building programmes, culturally diverse psychological services run by Life Without Barriers. For people of age over 12 is a useful resource to know about. And ISHA, Multicultural Women's Health Service, can also provide counselling and work within perinatal mental health as well. I showed this slide on a previous the talk that I did, and I just wanted to highlight that rates of diabetes, kidney disease, stroke, dementia, and heart disease are significantly higher in refugees as opposed to other permanent migrants, or in comparison with the rest of the Australian population. So, as a kidney example, disease as an example. Really, I think it's important to understand the impact of social determinants. So starting from things like access to clean water, healthcare, food security, housing, education, the fact that people may be more likely to be born at low birth weight, have increased risk of infections, poor access to healthcare, and the impact of stress on physical health. So we know that stress itself can increase blood pressure. There's also high rates of diabetes, hypertension, kidney stones, high risk of acute kidney injury from acute illness, which maybe isn't treated, as thoroughly as it may be in Australia, and really lack of access to prevention at all levels through primary and tertiary care. So health education, access to screening, lifestyle modification, medications, imaging, monitoring, all the things that we would usually do to manage kidney disease. So it's just, to consider that in your refugee clients. With disability, having a medical condition or disability does not prevent people from being granted humanitarian visas, unlike the usual route to get PR visas. So we really do see a full spectrum of disability. There's really limited screening, medical care, rehabilitation available to people overseas, and often individuals are very reliant on informal care from family and community members. So the settlement period and transition to coping in Australian context is actually quite challenging, and I think GPs can play a really crucial role in providing healthcare, assisting with NDIS applications and navigation of health services. Also highlight this HUDAS tool, which is being developed by WHO, which is quite a nice culturally appropriate tool that you can use to score disability, which can be used as part of evidence for NDIS access as well. And those barriers, again, NDIS access, getting the evidence for that can be challenging. And also there is a lack of culturally appropriate disability services and access to interpreter services. So I won't go through the disability case study that I had, because unfortunately I think we are running a bit short of time. So moving on to women's health. Just a few practice points, firstly around interpreter use, so considering gender preference for interpreter use, and also whether face-to-face or telephone preferences, people have preference for that. Remembering that rates of cervical cancer may be increased as the risk from country of origin is maintained, and encouraging participation in screening programs. Already mentioned menstrual issues. We find that dysmenorrhea can really significant impact on quality of life, ability to attend school, English classes, etc., and often not raised by patients. So worth exploring that. Reviewing previous obstetric history. So looking at possible complications, history may alert you to things like undiagnosed gestational diabetes, and also thinking about access to contraception. So consider if there's a risk of whether there could be a risk of reproductive coercion and abuse, or making sure people have choices around childbearing, because often women decide to delay adding to their families after arrival because they want to be able to learn English and settle in soon after arrival. Just ensuring appropriate screening for syphilis and hemoglobinopathies in the antenatal period as well. Consider screening all women for FDV, intimate partner violence, and seeing individuals alone with accredited interpreters, and considering the possibility of sexual violence, which is unfortunately more common in conflict zones. And I've just mentioned ISHA already. It's really worth looking at their website, because they have a whole enormous amount of services available to called women. FGMC, again, I don't have time to go into it in great detail, but we do see migrants from some high prevalence countries, and it does impact 130 million women worldwide. People may present with a history of previous obstetric complications requiring things like cesarean section or defibrillation, or may present with other symptoms such as recurrent UTIs, bladder dysfunction, chronic pelvic pain. We educate families about FGMC, and I wanted to highlight this SWIFT network, which aims to support health professionals across Australia, share expertise and resources on FGMC, which you can subscribe to. Other gender-based violence, just being alert to the possibility of things like forced marriage as a form of FDV, things like dowry abuse. King Edwards actually have some really good education sessions and resources on these topics if you want to learn more. And Life Without Barriers, who also run the culturally diverse psychological services, they have a forced marriage support, which I've put a link there. I'll give you a link afterwards. And just finally, I wanted to highlight the fact that we do see increasing numbers of LGBTQIA plus refugees, and in many countries, people are persecuted. They're at heightened risk of exclusion, exploitation, violence and abuse, and people may flee as a direct result of their sexual orientation, gender identity, gender expression, or sex characteristics, or due to other reasons. And people face many barriers to getting help and healthcare, including gender-affirming care. And the UNHCR are actively trying to identify challenges and help people find safety and protection. people may not have the support of their community from their country of origin in Australia, which can increase the risk of isolation. So we sometimes make referrals to places such as the M Clinic, or GPs specialising in gender affirming care. And if you are somebody who specialises in that area and you're keen to help out with the refugees that we see that are seeking that care, then please get in contact with us. I've also just highlighted a couple of other programmes, the Rainbow Migrants Lab, which is run by ECU and aims to provide community support to people, and also Transfolk WA have lots of resources as well. So I'm sorry to have rushed through that last bit. When I timed it earlier, I was on time, but obviously I've talked a bit more than I did then. I don't know if we have time for any questions.
Just a couple of quick questions if you want to pop it in the chat while I'm doing the final slides. So I can do the final slides. And if any questions do come up, then we will address them. If not, then you have the opportunity to submit it through the feedback form. So this is the North Metropolitan website. And the next webinar will be about providing holistic healthcare to children from refugee-like backgrounds in primary care. And that's with Dr. Tom Volkman. We will advise the date a bit later on. It's likely to be in September or October. Clinician Assist, I have mentioned in previous webinars, have pathways developed by local GPs in consultation with local specialists and subject matter experts. And they have a couple of pathways for primary care clinicians providing care to refugees, such as the Refugee Health Assessment, FGC or M, tuberculosis, migrant and refugee support services, and interpreter services as well. So please use this website, or if you have any questions, please email this email address or call this number. Thank you, and thank you to Dr. Zoe for your expertise tonight. I know I learned a lot. So please use the feedback form. Please drop any questions that you may have for Dr. Zoe, and then we will get them through to her and answered in the post-event email. Otherwise, if you'd like to leave some feedback about the webinar tonight and thank Dr. Zoe, please feel free to do so. I will also send this out in the post-event email. So thank you very much, Dr. Zoe, for your time and expertise tonight.
Thank you.
And thank you everyone for your time in attending the webinar. We hope you have a wonderful night. Thank you.